science, and obviously there's a lot more to be learned here. Other tests that I did, white count, it's up in the upper quartile, which tells me your immune system is activated, as I mentioned in my discussion 2 days ago on biomarkers. She's not anemic. Her hemoglobin is 13. Her metabolic panel is unremarkable. Look at that ferritin. That's pretty darn low. She doesn't have any iron stores, so fortunately she's not bleeding because she doesn't have much reserve in her iron. And you generally don't like to put people with inflamed intestines on an iron supplement, but in this case, I don't think you got a choice. I think you've got to supplement with iron. I mean, look at her serum iron, 27 micrograms or 7% saturation. So she's clearly not keeping up with her daily iron requirements. Her gastroenterologist had brought in, had her do an H. pylori breath test, a urea test. That was negative. That's fortunate, but I don't think that really helps us with the bloating, which we'll get to in a minute. So what did I do with this patient? The number one recommendation that I made was time-restricted feeding. 16 hours fasting, 8 hours eating. I'll come back and explain why, but I think this is one of the most powerful things you can do for somebody with inflammatory bowel disease, is to give them this long overnight period where they're not eating anything so that you can enhance autophagy. At least that's one of the theories about what's going on. I also suggested that in addition to that, that she start keeping a diet diary and that she look into a basic elimination diet. She was already very savvy about her diet. She was on a gluten-free diet. I think ever since she'd had the colonoscopy, she knew something was off. Now, this is different than assuming she's got celiac disease. She'd been tested for celiac with the duodenal biopsy. It was negative. Does that mean the person can't still have problems with gluten? No, you can still have problems with gluten. It's just not because of celiac disease, but you can still have an inflammatory reaction. I started her on low dose naltrexone. Some people can react when you give the target dose of 4.5 milligrams. So it's become my practice to begin people on a lower dose, 1.5 milligrams a day, make sure they can handle that, and then gradually head towards 4.5 milligrams. There are published studies on naltrexone for Crohn's disease. Seems to be helpful. It's an immunomodulator. I mentioned this in my immunomodulator lecture. It's safe, it's inexpensive, it's non-toxic. So I say, why not?
It's 1:30.
I would consider it to be, at least for me, part of my standard of care for people with Crohn's disease. I have tried it in ulcerative colitis, haven't seen much of a benefit. Still might try it in some patients. I gave her Saccharomyces Bilardii. What is Saccharomyces Bilardii? It is a specific strain of Saccharomyces cerevisiae, which is baker's yeast and brewer's yeast, and also the kind of yeast found in wine. But Saccharomyces Bilardii actually was found in lychee fruit and mangosteen. It's a specific strain. It used to be thought that it was an entirely different yeast than Saccharomyces cerevisiae. It's not entirely different, but it has different metabolic characteristics. I mentioned Saccharomyces Bilardii in my immunomodulator lecture because it has very potent effects for healing the gut lining. Now, I'll come back to this in a minute, but one of the pathognomonic blood tests that you see for Crohn's disease is elevated anti-Saccharomyces cerevisiae antibodies. And so you might think Saccharomyces Bilardii, that's not a good idea. Isn't that going to have a similar molecular structure to Saccharomyces cerevisiae? Well, this has been studied. First of all, they've given Saccharomyces Bilardii to people with Crohn's disease and not seen an exacerbation. In fact, seen improvements in the Crohn's. And they've also measured anti-Saccharomyces cerevisiae antibodies before and after giving the S. Boulardii to people with Crohn's, and they did not see an increase. So to me, it's one of these great mysteries is why do you see those antibodies in Crohn's? And what do they have to do with eating certain yeast? Do they have anything to do with baker's yeast, brewer's yeast, wine yeast, or Saccharomyces Bilardii? This is a big unknown about this, but the known is that S. Boulardii is helpful. I also gave her a powdered drink that combined some nutrients we talked about, curcumin. I like the curcumin phytosome because it's a little bit better absorbed. It's going to work topically and systemically, along with Boswellia phytosome, a LOX inhibitor. You've heard about that. Glutamine and aloe vera gel. So a nice combination of all of these things to go after the leaky gut and the inflammation. Also for a leaky gut, N-acetylglucosamine, 4 grams a day, which is a pretty healthy dose. There's a number of studies showing that that's helpful with leaky gut syndrome. I gave her butyric acid, a short chain fatty acid. That's been shown, again, to help with gut inflammation and leaky gut syndrome. I gave her 2 grams a day of EPA and DHA and 5,000 units of vitamin D. Could have given her more, didn't want to overload her. I am going after inflammation and leaky gut. So, time-restricted feeding. You may say, well, God, why did you pick that? I mean, that seems kind of random. Like so many other diets you could do, etc. Look at this, clinicaltrials.gov, impact of time-restricted feeding in Crohn's disease. Somebody else thinks that time-restricted feeding might be helpful. What's the rationale behind this? Oh, and by the way, who is that someone else? Cornell, Weill Medical College of Cornell University, thinks that there's enough of a plausibility behind time-restricted feeding that they actually have started a clinical trial. It's going on right now. They're recruiting right now for TRF. So the whole idea is that when you go that chunk of time, 16 hours or so, I think the benefits start about 14 hours, that you improve autophagy, that you improve bacterial clearance, that you improve gut permeability. So this is a really powerful way of thinking, that it's removing things, it's not adding things. Now, we could also use medical foods to do the same thing, but this is cheap and it's easy and anybody can do it. And I'll comment a little bit later on what she said about that. I also did a pretty comprehensive panel on her that included a number of genes, some inflammatory markers, etc. So let's look at the inflammatory markers on the right, in the right column. Let's go down to the bottom. Her CRP is 18. And this particular lab has their upper level of normal 13, right? So when you're talking about the ranges, understand every lab's got a little bit different range. 18 is not enough to knock your socks off, but it tells you there's inflammation going on. Her SAA, we talked about this, her serum amyloid A, which is a acute phase marker, that was not elevated. Again, the acute phase has a number of different pathways involved. And just because the acute phase of inflammation is activated doesn't mean that all the different markers are going to be elevated. She had normal levels of ICAM, VCAM, and VEGF. So it was the CRP that really stood out in this particular case. Then let's go to the left and look at the serology. Sure enough, she's got elevated anti-Saccharomyces cerevisiae antibodies, ASCA. Classic finding that you get with Crohn's disease, pretty significant elevation in IgA and IgA, IgG and IgA. Skip down to the bottom that's not boxed and you see IBD-specific P-ANCA. That's perinuclear anti-neutrophil cytoplasmic antibody. Now, the pattern that you're looking for in inflammatory bowel disease is that one or the other of these antibodies is going to be up. With Crohn's disease, you typically see increased ASCA and decreased P. ANCA. The opposite is true with ulcerative colitis. You see a low ASCA and an increased P. ANCA. Why this occurs, we don't know. These are just observations that have been known about for a very, very long time. So these are kind of classic tests that are done. This particular lab also added some anti-proprietary antibodies that were also positive and also somewhat pathognomonic for Crohn's disease. In addition, she had some genetic variants. Most of these have to do with autophagy, and in particular, the one at the top, the ATG is an autophagy. That's what the AT stands for. She's got one genetic variant in that. So she's not homozygous or anything. That's a pretty good sign, but she does have a consistent pattern with her genes that suggested of Crohn's disease. So I took this one step further. I specifically wanted to look at NOD2. And that's what you see on the right here that I've boxed that out. There's 3 different variants of NOD2. And she was heterozygous for one of them, the 1007FS variant. What is this? Okay, NOD2 is in immune cells, but it's particularly concentrated in Paneth cells, which is something that is a set of cells that are found in the ileum. Now, typically, what would happen in a healthy person is certain bacteria would interact with NOD2, which is a pathogen-related receptor. It's right up there with TLR2, et cetera, but it's instead of being on the surface of the cells, it's intracellular. So this is an intracellular pathogen-related receptor. And in a healthy scenario, the NOD2 is going to respond to bacteria that are found in the small intestine. And in response to that, they're going to make antimicrobial peptides. Yes, cathelicidin, defensins, etc. What I'm saying is that people that have the NOD2 variant, which is a loss of function variant, are less capable of making antimicrobial peptides. And so what you get is you get an accumulation of bacteria and bacterial components. And that's what's going on with Crohn's disease. It's autoinflammation. It's not a reaction of the immune system to specific tissues like the lining of the gut. Instead, it's accumulation of certain bacteria that are creating fistula and abscesses, etc. That is autoinflammation. Autoinflammation, which is inflammation in situ. And you're going to deal with that in a different way. Now, this lab says with these genetic variants, she's got a very high probability of complications like strictures, fistulae, etc. And what that tells me is not that I should worry more, but that I should be more aggressive. I'm telling her, you can't just go on a program for a little while now and then expect everything to magically go away, right? Whatever program you get on, you got to stay on. So she comes back in 2 months. She's better. Her pain's better. She's still a little constipated. She felt better on a restricted diet. She's taken out gluten, soy, corn, dairy, rice. She feels particularly better when she's fasting. So when she goes with these 16-hour intervals without eating, she noticeably feels better. The big persistent complaint is bloating, which we'll get to in a minute. Because of that allergic reaction with the hives, she went to see an allergist who did skin testing, who said, well, you're not reacting to anything that I can find. So you just kind of had this weird reaction. We can't explain it. Maybe that's autoimmune urticaria. You do have a high IgE. I don't know if I buy that. I think she just had an allergic reaction to metronidazole that didn't show up with the skin testing. The allergist said, well, I don't know what else to tell you. Take cetirizine if you have this problem again. She'd had some yeast vaginitis that she took fluconazole for. She went back to the gastroenterologist who said, Humira, you need adalimumab. You got to take that. But the patient and her mother had done a lot of research and said, I don't buy it. I don't want it. They were just firmly against it. I tried to stay neutral about this, but I said, well, would you take other drugs? She says, okay. So I put her on an extended release budesonide. It's not as powerful as oral prednisone, but it doesn't have the systemic effects. I think it's a pretty good drug, actually. So put her on 9 milligrams a day, extended release, same supplements that I mentioned, made sure she was taking the iron at 36 milligrams BID. I like the bisglycinate because it seems less inflammatory. At 4 months, she's 30 to 40% better. Her energy's better in particular. She's back to her normal lifestyle. Her right lower quadrant pain, much less frequent, less severe, etc. She'd gone to see an acupuncturist. She'd started on a TCM formula called cinnamon pearls. This is something I really encourage, as I think that traditional Chinese medicine is a great complement to the kind of work we do in functional medicine. I see an acupuncturist myself. I don't always understand what she's telling me and what I'm taking, but I do see it being very helpful. So I appreciate the kind of side-by-side thinking of these two strategies. She had tried the specific carbohydrate diet, which has been recommended for Crohn's. She didn't like it. In fact, the diet had encouraged her to add dairy. She did, got worse. So she went on the autoimmune paleo diet. Here's her labs. I rechecked her calprotectin. It's still up. Oh my God, really? It's still up. Her IgE is still up. Her CRP is still up. She's feeling better, but there's this lag on her lab. So I'm like, I don't know. I think we're not quite getting this. So the main thing that I did is I changed her from the extended release budesonide to an enteric coated budesonide, which is released further up in the intestine. So I've been going for trying to hit the first part of her colon. This was more directed towards her ileum. As it turned out, that seemed to be a choice that made the big difference. When she first went on the budesonide, she felt dramatically better. So it clearly had helped, but I think it was just being released too far down in her GI tract. At 7 months, she says, I'm having more and more good days. My pain is practically gone. My constipation is better. I had some respiratory stuff going on. I thought it was COVID. I was negative. She'd been on the autoimmune paleo diet, but she said, that is just too restrictive. A lot of my patients tell me that it's too much. I miss the nightshades. What's the data that nightshades are a problem? Well, Dr. Deanna Minnick, who's one of our teachers in the functional medicine program, did a really good analysis of this, went through all the literature, and she said, I can't find much there. I really can't find very good data that nightshades are that inflammatory for most people. It maybe is worth a try to see, but people shouldn't be stuck on this idea that nightshades are bad for everybody and that you should avoid them like the plague. And that's been my experience with a lot of patients with autoimmune disease, is that the nightshades haven't made that much of a difference for most of them. So she'd liberalized her diet. She was not reacting. She wanted to know if she could add hot sauces and peppers. Well, Dr. Yehuda Schoenfeld says that hot peppers, which are nightshades, are one of the best things that you can do for autoimmune disease. I repeated her interrography. There was a definite improvement in her bowel pattern. This was months later, right? Months later. There's still some thickening of her upper colon and of her ileum. The fistula are still there, but the overall pattern looks better. And get this, her CRP is now less than 5. So I've been really reluctant to do this. To be honest, I had said, you had a history of a stricture. I think maybe you should consider a biologic. So I was actually encouraging it, but she basically said to me, and I quote, hell no, I'm not going to do it no matter what. So at this point, I got a breath test on her. It showed hydrogen sulfide, which has been shown to be inflammatory in excessive amounts. I had her bump up on the naltrexone to 4.5 milligrams. At bedtime, I thought it was time to taper the budesonide. She'd been on long enough, several months. I added bovine serum immunoglobulin. I put her on a prebiotic with bacteriophages that are specific against E. coli. For the bloating, which we really hadn't addressed before, I put her on an antimicrobial concentrate. And I added something significant, Agaricus Blasey, a very, very interesting mushroom. And I'm going to come back and talk about that in a second. So here is her breath test. This is a test that looks for hydrogen, methane, and hydrogen sulfide. I think if you are not testing for hydrogen sulfide, you may be missing a significant number of cases of SIBO. You can see in her case, the hydrogen was slightly elevated and the hydrogen sulfide was significantly elevated. So it felt like we should go after that. And that's why I used the antimicrobial formula. Here's $1 million question. I haven't seen a lot of papers linking SIBO with Crohn's disease, but it makes a lot of sense, doesn't it? I mean, this is a problem with accumulation of bacteria because of defective immune response. So doesn't it make sense that SIBO would be a contributing factor? It should be treated, I think. Not necessarily with antibiotics. I don't want her to have another allergic reaction. So I use something much more gentle that she can do over time. Okay, one paper that I wanted to show you. Effect of medicinal Agaricus Blasey on symptoms, fatigue, and quality of life in patients with Crohn's disease. A randomized, single-blinded, placebo-controlled study. Pretty impressive study. Now, I can't get this particular product that's sold in Europe. All I can get is Agaricus Blasey, but since seeing the study, I put patients with both Crohn's disease and ulcerative colitis on this. And it does significantly improve symptoms. I've seen it. I just talked to a patient with ulcerative colitis a couple of days ago who said, you know, I think that made as much of a difference as any supplement that you put me on. And he was on mesalamine. So I think this has a lot of potential. It's an immunomodulating fungus. Very powerful thing to use. So just a few things about risk factors, positive family history, Ashkenazi Jews, which actually pertains to this patient. The big thing about Crohn's disease is, yeah, there's a genetic component, but why is it increasing? Why is it increasing in first world countries? Does it have something to do with being too clean? Or maybe we smoke more cigarettes, or we use more antibiotics, or take more NSAIDs. We eat more omega-6 polyunsaturated fats. We don't have enough fiber, vitamin D. We have more dysbiosis. You know, the bottom line is there's environmental factors. This is not strictly genetic disease. There's environmental factors involved. And if there are environmental factors that trigger it, couldn't environmental factors get it under control or reverse it? That's really the $1 million point that I would like to make here. If the environment triggers it, couldn't the environment be involved in getting it under control? I've already told you what this, the pathophysiology is thought to be. It's defective bacterial clearance. This is autoinflammation. And part of this core process of autoinflammation is overactivation of the NLRP3 inflammasome, which I talked about on day one. And that's in combination with altered gut mucosal integrity and decreased production of antimicrobial peptides, overall defective innate immunity. So we want to not suppress the immune system. We want to support the immune system. We want to support the immune system. So treat the leaky gut, increase antimicrobial peptides, and support innate immunity. That's the strategy here. Yeah, it's good to know about the genes. NOD2, ATG16L1, autophagy-related genes. Know about these genes, but genes are not destiny. We don't want to get stuck here. Couple more slides, and I'll wrap it up. I just wanted to show you that there is this continuum between autoinflammatory diseases, which is inflammation in situ. That includes Crohn's and ulcerative colitis, and autoimmune diseases like the Sjogren's case that I showed you. They're both characterized by excessive chronic inflammation. But in one case, the immune system is specifically attacking certain tissues in the body, like the parotid glands. In another case, the inflammation is happening in situ. So you deal with them in slightly different ways. Just want to zip through. We talked about all this. Promising treatment options. Vitamin D, was that a promising treatment option? Hopefully, we've hammered that down to you as being something we should use. It induces antimicrobial peptides. Essential fatty acids, DHEA, poop transplants. A lot of potential, especially for inflammatory bowel disease. We've talked about most of these phytochemicals, especially sulforaphane. Naltrexone on the right, we've talked about. Agaricus Blasey, I think is a wonderful mushroom, a wonderful fungi for autoimmune disease, and Cordyceps sinensis, which we haven't talked about, but has data on it for lupus nephritis. It's a fungi that I take myself. It's a very good adaptogen. So a lot of treatment options that are out there. So we've talked about autoimmune versus autoinflammatory diseases. They're a continuum. Let's look at both of these as a maladaptive process rather than a consequence of bad genes. Let's consider that innate immunity plays a bigger role in autoimmune disease than we appreciated. Most mainstream treatments for autoimmune disease go after T cells and B cells. They're not doing much for innate immunity. We can strengthen and regulate innate immunity as a different and complementary strategy. It's not an either or, it's in addition to. Tolerance to microbes plays a major role in tolerance to self. So we want to restore tolerance. Okay. And where is that intolerance occurring? Epithelial and mucosal surfaces. We want to build good barriers. Good fences make good neighbors. Healthy barriers are the best protection we've got against inflammation and autoimmune disease. Thank you very much.